Give it another minute to allow others to sign on before we start. Morning, Peter. Good morning, Ayesh. Thanks for joining. Okay, good morning, everyone, and welcome to Journal Club for March 2024. We start with a land acknowledgement, and we recognize that many Indigenous nations have long-standing relationships with the land upon which the work of the University of Toronto's Department of Medicine is conducted. We acknowledge our presence on the traditional territory of many Indigenous nations, including the Mississauga, the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. Today, this land is home to many diverse First Nations, Inuit, and Métis peoples, and we are grateful to have the opportunity to live, work, and gather on these territories that, in many cases, remain in dispute. There are many overlapping land claims and complex treaty relationships. For example, the area covered by the Crawford Purchase and the Rideau Purchase, which together cover much of eastern Ontario, included Algonquin traditional territory, despite the Crown only making the purchases in the treaty with the Mississauga. Focusing on Ottawa, our country's capital city, for example, Parliament buildings sit on unceded Algonquin territory. Today, as they did pre-contact, the Algonquin live on both sides of the Chisissippi or Ottawa River. Although they have centuries-long history of submitting petitions to the French and British, to this day, they continue to be denied their land and land-related rights. We have two great presentations today. The first, a short presentation from one of our clinical fellows, Dr. Chandni Chandramouli, who comes to us originally having studied medical school at Christian Medical College in Vellore, India, and she completed her residency in internal medicine in Pondicherry, India. Her areas of interest include comparative analysis of healthcare systems and exploring the influence of culture on decision-making. Dr. Chandramouli, a very warm welcome to you. Please feel free to share your slides and to start.
Good morning, everyone. The article I've chosen today was published in the journal Hypertension in August 2023 and is entitled Systolic Blood Pressure Time and Target Range and Cognitive Outcomes, Insights from the Sprint Mind Trial. I have no conflicts of interest. I will be going over some background, followed by a summary of the trial, the critical appraisal, and finally the conclusions and take-home message. To set the stage, I'll briefly summarize the trials that the current analysis is based on. As we all know, the SPRINT trial in 2015 showed that in non-diabetic patients with hypertension over the age of 50 with increased cardiovascular risk, targeting a systolic blood pressure of less than 120 compared with that of 140 resulted in lower rates of fatal and non-fatal adverse cardiovascular events and death from any cause. However, it's worth noting that the intensive treatment group had higher rates of hypotension, syncope, and acute kidney injury. The SPRINT Mind trial, which included SPRINT patients that completed at least one follow-up cognitive assessment, showed that an intensive SPP target of 120 compared to 140 did not result in a significantly lower risk of probable dementia, which was the primary outcome. It should be noted, however, that the study may have been underpowered for this endpoint due to early termination and fewer than expected cases of dementia. On the other hand, intensive BP control did reduce the risk of mild cognitive impairment as well as the composite of MCI and dementia. This finding, as we know, has been referenced in the CCC DTD5 guidelines to support a grade 2C recommendation for considering an SPP target below 120 for middle-aged and older adults with hypertension and vascular risk factors. So the current study set out to answer the question, in SPRINT-MIND patients, putting the intervention and control arms together, was there an association between time and target range of systolic blood pressure and cognitive outcomes? So what is time and target range? TTR, as I'll be calling it henceforth, is defined as the percentage of time that the BP level is within an appropriate target range. So greater the TTR, better the BP control. Compared to blood pressure variability, it is thought to be a more wholesome metric as it incorporates mean BP, variability, as well as time. Prior studies have shown an inverse association between TTR and cardiovascular outcomes. Now, I've put up this slide only to show that the linear interpolation method, which is the method used in this study to calculate TTR, is simple and feasible even in the clinic setting. All you need to do is define a target range for your patient, record their BP at serial intervals, and the rest is simple mathematics. In the interest of time, though, I will save the explanation for later. Let's start with the trial outline with a recap of the patient profile in question. SPRINT included around 9,000 patients from various sites in the US who were 50 years or older with a screening BP of 130 to 180 and at least one of the following CV risk factors, as I've shown. They've excluded patients with diabetes and prior stroke. The SPRINT-MIND trial included those patients who had completed a follow-up cognitive assessment and excluded nursing home residents and patients with known dementia or treatment for the same. The current post-hoc analysis includes participants of SPRINT-MIND with at least 3 BP measurements from baseline to month 3. Coming to the study design, the data was obtained from the publicly available SPRINT-MIND data. In order to calculate the TTR, the SPP target range was defined as 110 to 130 for the intensive arm and 120 to 140 for the standard arm, which is consistent with the approach of previous studies. The BP measurements at baseline and months 1 through 3 were collected. The TTR was calculated by the Rosendahl method of linear interpolation, as previously mentioned. To briefly describe how cognition was assessed in SPRINT-MIND, after a screening assessment administered to all patients, which included a MoCA, patients who scored below a predetermined cutoff were administered a more comprehensive battery, which is outlined here. All participants were contacted for follow-up cognitive assessments at 2 and 4 years, and another follow-up at study closeout if it was more than 1 year after the 4-year mark. However, follow-up could not be completed in all participants, as we'll soon discover. Based on the data, 2 blinded adjudicators classified the patients as having no cognitive impairment, mild cognitive impairment, and probable dementia. For this post-hoc analysis, as well as the original SPRINT-MIND trial, the primary outcome was the occurrence of probable dementia. The secondary outcomes were the occurrence of MCI and the composite of probable dementia and MCI. In this analysis, it's important to remember that the intervention and standard arms were grouped together. The patients were divided into tertiles of SBP TTR. The association of TTR and cognitive outcomes was analyzed by the Cox regression model and presented as a hazard ratio with 95% confidence intervals. While the primary intent was to analyze the cohort as a whole, the supplementary file also gives us the analysis for both arms separately. The cumulative incidence of dementia stratified by the TTR group was calculated by the Allen-Johansen estimator with death as completing risk. From this flow diagram, we see that of all SPRINT participants, about 10% roughly were not included either due to lack of cognitive follow-up, non-availability of 3 BP readings, or other missing covariates. This introduces the potential for selection bias in that if the excluded patients were more likely to have severe cognitive impairment or unstable blood pressure control, their absence from the analysis could lead to an underestimation of the true association between TTR and cognitive outcomes. Coming to the results, in this baseline characteristic table, we see the 3 tertiles, each having roughly 2,700 patients, and tertile 1 on the left represents the group with the least time spent in range. Firstly, we see that the lowest tertile group was older, although I would say that while the p-value is significant, numerically the mean ages were quite similar. There were significantly more women in the lowest tertile group. The patients in the lowest tertile had significantly more pre-existing cardiovascular disease, chronic kidney disease, and a higher baseline ASCVD risk score. This tells me that the group where the BP was more often out of range had more comorbidity burden. Interestingly, the patients in the lower tertile were more likely to be on 3 or more antihypertensive drugs as compared to the other 2, which is a reflection of the difficulties faced in controlling the blood pressure in this group. While the BMI was calculated to be significantly lower in the first group statistically, to me, numerically, these values don't seem too far apart across groups. The lower tertile had a higher number of smokers. It's interesting that the patients assigned to the intensive control arm fell in the lower tertile, which suggests to me that while they were assigned to a stricter target, they did spend a fair amount of time out of range. It is not surprising that the lowest tertile had a higher mean and baseline blood pressure. While the difference in the mean MoCA score across the groups was calculated to be statistically significant, numerically these values are quite close, and I doubt it would be clinically significant. All that to say, there were significant between-group differences across the tertiles, and so to detect a truly valid relationships between TTR and dementia, these factors would have to be adjusted for in the multivariate analysis. In this plot of cumulative incidence of dementia against time, we see that as time goes on, the patients in the lowest tertile of SBP-TTR have the highest cumulative incidence of probable dementia and vice versa. In this table summarizing the Cox regression analysis, we see that in the univariate analysis, while comparing the TTR with probable dementia, the hazard ratio was 0.78. This ratio represents the hazard for probable dementia for every 1 standard deviation increase in TTR. In other words, every 1 standard deviation increase in time and target range was associated with a 22% lower hazard of probable dementia. Perhaps more relevant is the multivariate analysis, as it adjusts for the between-group differences that we saw in the baseline characteristics, such as age, CV risk, kidney disease, mean BP, and MoCA score. After adjustment, the strength of the association between the TTR and dementia decreases slightly, but remains significant. The hazard ratio for the secondary outcome was not statistically significant in the multivariate analysis here and here. Depicted here are the cubic spline models where we have the TTR percentage on the x-axis plotted against the hazard ratio on the y-axis. The dotted red lines here and here represent the upper and lower limit of the confidence interval respectively. In the first graph, we see that as the time spent in range increases, the hazard ratio for probable dementia decreases to below 1. This plot tells us the same thing in numbers, where as we move from a lower to a higher TTR, the incidence of probable dementia decreases and the hazard ratio moves below 1. This is a table from the supplementary file, which to me answered the question, what happens to the hazard ratio when we split the cohort back into intervention and control arms? And what contribution or effect did the intervention strategy itself have on this association? We see here that when the arms are separated, the hazard ratio remains significant, which is good. The p-value for interaction is more than 0.05, indicating that the type of BP target likely did not play a role in reducing the risk of dementia, and it was indeed the TTR that made the impact. At least that's how I interpreted it. So to summarize the results very quickly, over a median follow-up of 5 years, where probable dementia occurred in 305 patients of the total, the cumulative incidence of dementia decreased from the highest to the lowest BP tertile. The primary outcome of probable dementia had a significant association with TTR, while the secondary outcome largely did not. Before moving on to the critical appraisal, I'd like to highlight some important considerations and caveats while interpreting the results of a post hoc analysis such as this one. We all know that a post hoc analysis is conducted after data collection without a pre-specified hypothesis. So if you go digging for data, you might get spurious findings. There's the risk of selection bias and confounding. These analyses are generally meant to be exploratory and hypothesis generating, and any associations should be interpreted cautiously and confirmed by further research. It's important to avoid over-interpretation to support your preconceived beliefs, and there's always the risk of publication bias favoring statistically significant results. For the appraisal, I adapted the questions of the CEBM Oxford tool to fit the context of a post hoc analysis. Starting off, I do think the research question was well defined and the study design was appropriate. As this is a post hoc analysis, the sample size was not calculated beforehand for this outcome. And also, the primary trial was underpowered due to a lower than expected dementia rate and early termination. With respect to the group studied in this analysis, they were not similar at baseline, but the differences were adjusted for in the multivariate analysis. I will say, though, that the SPRINT-MIND patients at baseline, the baseline characteristics were similar in both groups. We do know that the SPRINT-MIND trial was not blinded, although the adjudicators who assigned the outcomes of dementia were blinded to the trial assignment. The follow-up was complete to some extent, as in the completion rates were 90% at 2 and 4 years and 60% at the extended assessment. We've looked at the results and what they mean in detail. With respect to precision, the confidence intervals are narrow and on the same side of 1, and the p-value is significant. In terms of applicability, I would say the results can be applied to our patients, but the exclusion of diabetes, prior stroke, and nursing home residents was significant. The strengths of this study are that it included a simple and practical metric that, as I've shown, is easy to calculate, and the fact that the data was based on a meticulously executed trial. The limitation was, in a trial where BP was mandated to be closely controlled, SPP changes could be limited and TTR could converge. As an analogy, I'd like you to consider this example. If I were to compare noise levels in different parts of a library, how much variability would I really get? Secondly, as we know, TTR was not a predefined metric in the original trial, inviting the possibility of confounding factors. Thirdly, prior stroke and diabetes were excluded, limiting generalizability. And finally, one cannot rule out reverse causation, as in a patient with cognitive impairment may have poor medication compliance, which may cause him to spend less time in target range. As we know, the way to exclude reverse causality is to exclude patients with prevalent disease and lengthen the duration of follow-up. In conclusion, this post-hoc analysis of SPRINT-MIND showed that higher time in SVP target range was significantly associated with a lower hazard of probable dementia, independent of target SVP. As a clinician, this tells me that focusing on maximizing the time spent within the already existing SVP target could be more realistic as well as helpful rather than pursuing stricter treatment goals. In future, I hope that a randomized trial with a longer follow-up and wider representation would be able to confirm this hypothesis. I'd like to quickly point out that that a similar post-hoc analysis of SPRINT-MIND was published around the same time by a different group in the Journal of American Geriatric Society with similar findings. For the take-home message, I'll make a feeble attempt at Harry Potter-inspired poetry and say that regardless of BP target, whether lax or stern, selecting a range is our prime concern. Strive to stay within it as long as you can to keep dementors away from the mind of man. Thank you for your time and attention.
Thank you, Chandni, for quite an excellent presentation, very efficiently presented, and I love the poetry at the end. Gary has his hand up. Go ahead, Gary.
Thanks. Great presentation. Really enjoyed it. And the originality at the end was terrific. I'd just like to make actually 2 comments. And those who've been involved with me participating in these rounds for years will hear a similar comment that I've made many times. When I look at the comparison of the baseline characteristics, there were so many differences between the groups. I'm very skeptical that statistical maneuvering to try to make the groups comparable can really achieve that in an absolute way. So I'm very skeptical. Those groups are so remarkably different with so much more comorbidity in the lower tertile group and various other factors. So that's one point that makes me skeptical. The other thing that I was, I guess, a bit surprised about were looking at the MoCA scores. So in the 2 higher tertile groups, they were 23, and in the lowest group, they were 22. Those are below what even the more stringent characteristic of MCI usually is. I'm just surprised at how low those MoCA scores were. And what does that mean? So I'm going to leave it at that, but great presentation. Thanks very much.
Thank you.
Thank you, Gary. Jen, go ahead.
It's a great presentation. And one thing that you touched on that I think might have been interesting, I'm not sure if they did this analysis though, so please let us know if they did. You showed a slide at the end where they had the interaction term, and that was whenever they were looking, that was not for the TTR analysis though, right? That was an analysis from SPRINT-MIND before, was that right?
No, it was an analysis for the TTR. It was not from the original.
That was for the TTR. So they derived the interaction term for the TTR based on the groups that were originally analyzed in SPRINT-MIND. Okay, then that's actually really helpful because, as you said, it's like underpowered, but the interaction effect actually didn't show a difference then between the groups. But then, because I think whenever you were talking about it, you were saying it was higher versus lower. So they were stratified by their group, but it was also incorporating TTR. And actually then there was no difference whenever they looked at the interaction term. So that would potentially suggest that at least whenever they restricted it to the as randomized groups, which, you know, I have to remember, like, those groups I think were a little bit better balanced and at least randomized, as opposed to being separated into the observational data as they were, is really helpful. But I think it would suggest then that perhaps the TTR maybe wasn't as effective, but underpowered. And so I agree with your conclusions that they need a bigger, like a trial meant to look at that in the future. So great work.
Thank you.
Thank you, Jen. Chandni, can I ask, I know that there was funding, or the Alzheimer's Association funded an extension of the original Sprint Mind trial. I think they called it the Sprint Mind 2.0. I never heard of any of those. In your research, did you come across whether the Sprint Mind 2.0 was published?
To my knowledge, it hasn't been published yet, no, but I did see mention of it. I didn't see results though. Great.
Any other questions from the group? Barry in the chat says great presentation. So thank you very much for that. And we will move on to our second presentation of the morning. It will be presented by Dr. Farid Medleg, PGY4 Geriatric Medicine subspecialty resident with a special interest in cardiology, to present to us today on the association between recently raised anticholinergic burden and risk of acute cardiovascular events. Farid, please go ahead. Welcome, and please go ahead.
Thank you, and great presentation to Chandni. It's going to be a tough act to follow. I will do my best. I just want to make sure, can somebody give me a thumbs up that the sharing is okay? Okay, so as Dr. Gandel mentioned, the title of the study is The Association Between a Recently Raised Anticholinergic Burden and the Risk of an Acute Cardiovascular Event. This was published in the BMJ in September of 2023. So I have no conflicts of interest to disclose. The objectives of today's talk will be to review the indications and harms for anticholinergic medications, which I'm sure will be known to everybody at this talk. We'll go over something called the Anticholinergic Cognitive Burden Scale, which is used to measure a patient's load of anticholinergic medications. I'll be referring to this as the ACBS. We'll then go over the study PICO methods and results. We'll have a discussion about the study results, critical appraisal, and then we can get into a bit of discussion about the implications for our practice as geriatricians. So the indications for anticholinergic medications should be known to most of us. You'll see obviously that medications are used across multiple body systems because anticholinergic receptors are present virtually across the entire body. And these medications we know well where the anticholinergic property is actually contributing to its therapeutic effect. Some medications that we use less often or don't use at all also have anticholinergic properties. And so you can see across the medical field that anticholinergic properties are widely used. Another group of medications that we often come across or use ourselves is medications where anticholinergic properties are actually not part of the therapeutic effect. Antipsychotics, TCAs, antihistamines. And this is actually something that we deal with a lot, where we're looking for a therapeutic effect and we have to measure the risk of whether we're going to send harm to our patients because of these unfortunate side effects. In terms of the harms, anticholinergic medications can cause harms very quickly or very slowly. Short term, again, they cause harms across multiple body systems because we have receptors in multiple body systems that respond to anticholinergic effects. We also know that we have central effects like agitation, confusion, delirium, and seizures if medications like these are used improperly or if simply a patient has a little bit of bad luck. We know that harms can extend into the medium and long term, and that's months and years. We know that in cognitively healthy adults, anticholinergic drug use is consistently associated with future cognitive decline or dementia. We know odds for this increase as anticholinergic burden increases. And we know that the association exists across multiple anticholinergic scales, depending on which one you use. Today, we'll discuss the ACBS. We know that anticholinergic exposure is associated with an increased risk of mortality and hospitalization. And we know that it's also associated with decreased physical function and quality of life. Looking at cardiovascular outcomes specifically, we know that in a 3-year follow-up, patients with dementia had higher risks of stroke. We know that in a 10-year follow-up, cognitively healthy adults had more cardiovascular events when using anticholinergics than patients who did not use anticholinergic medications. Most of these studies use a anticholinergic scale to measure the load of anticholinergic medications. Today, we'll be looking at the ACBS. And the way this scale functions is it classifies anticholinergic drugs into 3 categories. Drugs with an ACB score of 1, 2, or 3. Drugs will make it into the first category, giving a patient a score of 1 if they have in vitro evidence of cholinergic antagonism. Drugs will make it into the category with a score of 2 after being assessed by an expert panel and known to have anticholinergic side effects. Drugs with a score of 3 are those like a score of 2, but that are well known to cause delirium inside of the literature. And we know that specifically with the ACBS, increases in a score are associated with risks of cognitive impairment over follow-ups of 6 years, and also with decrements in the MMSE. To date, there have been no studies that have examined the link between a recently raised anticholinergic burden and an acute cardiovascular event. So as I previously mentioned, we have more long-term data looking at acute cardiovascular event over the course of years, but not over the course of, let's say, days or months. And so this brings me to the study. So this study question essentially asked, in looking at patients with acute cardiovascular events, do they have a recently raised anticholinergic burden in the 30 days prior to their event? The study population was adults aged 65 years old. The intervention was a previously raised anticholinergic burden, so either 1 or more anticholinergic medications in what they call a hazard period. The study design itself was quite interesting. There are 2 control analyses that were done, one where patients were compared to themselves earlier in time than the hazard window, and one where patients were compared to age and sex matched controls who had a future cardiovascular event. So all study patients looked at and analyzed were ones who had acute cardiovascular events. The outcomes were myocardial infarction, stroke, dysrhythmia, conduction disorder, syncope, and cardiovascular death. The analysis excluded anybody with a CV event in the preceding 5 years. And the methods, we're getting into the methods. This was a nationwide population-based study in Taiwan. And the analysis followed a case-case time control design. And so I'm going to spend a few minutes getting into what that means for the group. This is actually made up of 2 separate analyses, a case crossover design and a control crossover design. Each of these analyses will give you an odds ratio. The odds ratio of each of these is subsequently divided, and that gives you the overall odds ratio for anticholinergic burden. So looking at the case crossover design specifically, this bar that you see that's highlighted at the top represents 1 patient or 1 group of patients. The current case event date is set by the day that the patient was admitted for their acute cardiovascular event. And the hazard period where their anticholinergic burden was measured was 30 days prior to the event. This is the hazard period. The patient was then compared to themselves at a reference period, which is prior to the hazard period. In this particular study, it was 60 to 180 days before the current case. And so the washout period was actually 30 days. The anticholinergic burden was measured in the hazard period and reference period, compared and divided, and that gave you your odds ratio for a recent anticholinergic burden increase causing a cardiovascular event or associated with a cardiovascular event. The weakness of this type of analysis when taken on its own is that there are actually 2 main influences causing raised incidence of cardiovascular events. And that can be the actual causal effect of the medication, theoretically, or underlying time trends in medication use. But this type of analysis just gives you 1 odds ratio and doesn't actually distinguish these 2 influences. Time trends exposure comes in two flavors. The first one is population trends, where a new drug can come to market and suddenly gets used by the entire population because it's advertised and very popular. The other one is a within individual influence, where symptoms of a impending cardiovascular event actually leads to more anticholinergic prescriptions. For example, a patient with an impending MI or heart failure can have symptoms of vertigo and get prescribed anticholinergic medications for those symptoms. In the analysis, it will look like the medication led to the acute cardiovascular event, but in actuality, it's a reverse causality. And so this type of analysis seeks to tease out these two effects. And it does so by a control crossover analysis. So you'll notice that the top bar is the analysis for the case crossover design. The bottom bar is the control crossover. What they did was they took patients that were age and sex matched to the original patient who had a future acute cardiovascular event 60 to 100 days in the future of the original patients that we looked at. And they did the exact same analysis with the hazard period and reference period. And so essentially what they're assuming is that if we take someone who's a bit further away from their acute cardiovascular event, the odds ratios are actually only influenced by time trend. And so this is a sort of representation of that type of odd. You take the odds ratio from the first analysis, the odds ratio of the second analysis, divide them, and theoretically you get the causal effect of a recently raised anticholinergic burden. So thank you for indulging me in that sort of deep dive in the pictures of this study. The population, as I said, was coming from a Taiwanese database. Anybody below the age of 65 or with a previous cardiovascular event within 5 years was excluded. That left us with about 317,000 patients. And any patients who couldn't have age and sex match controls with a cardiovascular event 180 days in the future were excluded. So we were left with 248,000 patients approximately. Here is a breakdown by comorbidity and by medication use between patients that were eligible and patients that were actually able to be matched. And I'd invite you to look at the column under the red arrows, which essentially shows the proportion of each subgroup. And they're essentially the same. So the conclusion I can draw from this is that the matching process didn't significantly change the study population, which I thought was a relative strength of this study. As I said, the data was retrieved from Taiwan's National Health Insurance Research Database. This is a claims database covering 99.9% of the population who are obtaining publicly funded medications that are prescribed. The anticholinergic burden was measured with the ACBS, and the analysis was a conditional logistic regression to estimate odds ratios with 95% confidence intervals for the levels of anticholinergic burden. On to the results. So the main results of the entire study can be summarized in this one table, and you'll notice highlighted on the left the comparisons that they did. Patients with an ACBS score of 1 and 2 were compared to patients with a score of 0. The group with a score of 3 or more was compared to the group with a score of 0. And the patients with a score of 3 or more were compared to the group with a score of 1 to 2. The case crossover and control crossover analyses are in the next two lines, and you can see the odds ratio for each. And then next to the red arrows is simply the division of those two odds ratios. And you can see that the odds ratios are greater than 1, with a 95% confidence interval that does not cross the line of 1. They did a subgroup analysis and essentially looked at each of the outcomes that the study was looking at individually. And the results were largely the same. Odds ratios were greater than 1 with a 95% confidence interval that did not cross 1. The only groups and the only subgroup analyses that approached the line of 1 were conduction disorders and syncope in groups with an ACBS score of 1 to 2 versus 0. So on to the discussion. The conclusions that the authors came to from this analysis was that older adults with acute cardiovascular events had higher anticholinergic burdens in the 30 days preceding that acute cardiovascular event as compared to the same patient 60 to 180 days before their event. The results were only partially explained by protopathic bias, or that reverse causality that I discussed. And so I will go back to the main analysis. You can see that the control crossover analysis in each group was actually had an odds ratio greater than 1. But then when the case crossover results were actually controlled for that, the odds ratios remained over 1, indicating there is a causal effect, but also there is an underlying time trend effect that's contributing to the odds ratios. There is also evidence of a dose-response relationship. Groups with higher ACBS scores actually had were associated with higher rates of acute cardiovascular events. What I didn't go over, because the analysis was actually quite in-depth, was the various sensitivity analyses that they did to ensure that their data was robust. There is no agreed upon threshold for what constitutes a high anticholinergic burden. And so what they did was they retested their results for higher thresholds, higher scores, groups with scores of 5 or more, groups with scores of 10 or more, and the results were largely the same. There is no consensus for what the best anticholinergic scale is. The ACBS is probably the most widely used, but they tested their results with multiple scales. The results were largely borne out as well. They decided to exclude patients with cardiovascular drugs used in the preceding year. We know that many cardiovascular drugs have mortality benefits for acute cardiovascular events. Excluding these patients, the results were still consistent. And they examined only patients with chronic conditions such as hypertension, dyslipidemia, and diabetes, knowing that these are results for acute cardiovascular events and that they're more likely to be captured inside of the drug database because they have prescriptions that are covered by the government. Again, the results were consistent, higher odds ratios for all these groups and all these comparisons. Moving on to the critical appraisal. This is consisted of 4 questions. The first one is, was the defined representative sample of patients assembled at a common point in the disease course? The question is slightly modified from the original tool because there is a time factor in the original question, and patients in this study were actually selected because of being a specific time away from their acute cardiovascular event. So I would say yes, patients were selected based on the date of an incident event, and these met specific criteria from a database covering almost the entirety of Taiwan's population. Was patient follow-up sufficiently long and complete? This question doesn't really apply. There was no follow-up. In fact, we looked at data prior to the event to do the analysis, so I don't really think this question applies to this study in particular. Were outcome criteria either objective or applied in a blind fashion? In a sense, yes. Outcomes of events were captured based on admission diagnosis using the ICD classification system. However, certain subgroups in acute cardiovascular events were excluded and no rationale was provided. The most stark to me was patients with heart failure, and they didn't really discuss it at all. If subgroups were identified, did adjustment for important prognostic factors take place? Overall, yes. Results were consistent across subgroups, as we saw. And as we briefly touched on, the analysis or the various sensitivity analyses done largely maintained the results of the primary analysis. So is this study generalizable? No patients who suffered cardiovascular events in the preceding 5 years were included. I think this is an important group to have left out, but I understand why they did it. In fact, they did a sensitivity analysis that excluded patients who were just on cardiovascular drugs for the previous year. There was a relatively high mean age. They selected for patients over the age of 65, but the mean age in each group was 78.3 years. And as everybody knows here, we see a lot of patients in their 60s and even some patients in their 50s. Very hard to generalize to a group of patients that are 10 or 20 years younger than who was seen inside the study. Some strengths of this study. Results were consistent across various sensitivity analyses and across subgroups. The 2 analyses, the case crossover and the control crossover design, were meant to control for time constant and time varying confounders, and I think that they proved that that was done with some efficacy. Moving on to limitations. Over-the-counter drugs and those paid for by patients privately are not captured by the database. The authors address this directly, and they claim that a restrictive analysis of patients with chronic conditions minimizes this bias. Their assumption in this claim, by my interpretation, is that patients with chronic conditions are less likely to use drugs not captured by the database, and I don't know how that's true. They simply stated that and then moved on. I don't see why a patient with hypertension, diabetes, and dyslipidemia would be less likely to use an over-the-counter medication that has anticholinergic properties. And so I think this is actually a large weakness of this study. They address that there is no consensus on what constitutes a high anticholinergic burden. The authors used an arbitrary cutoff of ACBS scores of 3 or more. This too they addressed in their discussion. And they also addressed it with their sensitivity analysis, redefining high thresholds to 5 and 10, and results were largely borne out. So I think they did do a fair job of addressing this weakness. There is no consensus on a standard scale to measure anticholinergic burden. Again, sensitivity analysis looked at multiple scales, and they redid the whole analysis using those scales, and the results were largely the same. Medication adherence is not captured by the national database. The authors acknowledge this as well, but they claim that adherence would be consistent across the hazard window, 0 to 30 days before an event, and the reference windows, which is 60 to 180 days before the event. Again, by my interpretation, their assumption is there are no differences in medication adherence approaching an acute cardiovascular event, and that patient wellness would largely be the same in these two windows. I completely disagree with this assumption. They themselves acknowledge that medications might be prescribed for symptoms as patients approach a cardiovascular event. And so I think that an assumption that a patient may change their medication adherence leading up to this is also fair. And so I think this isn't adequately addressed or captured by the study results. So the summary of this paper: older adults with acute cardiovascular events had a higher total anticholinergic burden in a 30-day hazard window as compared to the same patient 60 to 180 days before their acute cardiovascular event. This indicates that there is an association between a recently raised anticholinergic burden and acute cardiovascular events. The study was subject to some bias, but was strengthened by the multiple sensitivity analysis that they undertook. In addition, like previous studies, they showed that there was a dose effect for the adverse event associated with these medications. So is this study practice changing? My immediate answer is no, not yet. Geriatricians as a group already value deprescribing medications in older adults, and there's a particular focus on anticholinergics because we are very familiar with the side effects presented with these medications. The study may be helpful in the future in refining clinical protocols following acute cardiovascular events. If you think that a medication leads to an acute cardiovascular event, maybe there is a predilection in patients who just had acute cardiovascular events. However, they distinctly did not look at patients with an acute cardiovascular event within 5 years of the study period. And I think that clarification is needed exactly on whether equivalent ACBS scores are actually equivalent. For example, a patient with an ACBS score of 3 can have that score made up of a single drug worth 3 points or 3 drugs worth 1 point. And if you take the time to go back and look at the list of drugs that have 1 point associated with them, we see many medications like metoprolol and warfarin that actually have a mortality benefit in acute cardiovascular events or following acute cardiovascular events. So how does the anticholinergic effect of these medications interact with the anticholinergic burden? I think most studies would suggest that they actually help prevent them. And so I'd like to see analysis that actually distinguishes patients who only have drugs from the third category, the second category, and ones that have only drugs from a first category. Thank you very much for your time. Happy to open the floor to any questions or discussion.
Thank you very much, Farid, for a beautiful presentation and pushing the boundary on the complexity of methods that we're traditionally accustomed to. We'll start. Barry, I think, had his hand up first. Go ahead, Barry. And Farid, if I can ask you to stop sharing, just make it easier for it. Yeah. Thanks.
Fabulous presentation, Farid. Congratulations. Just one comment and one question. The comment is that there are old studies showing that people who've had strokes and heart attacks, when you interview them after the event, a lot of them say they had symptoms 2 or 3 weeks beforehand. So that emphasizes what you said as well. The other question I have is, I know that different ethnic populations can have different capabilities of metabolizing drugs, et cetera. So, for example, alcohol is a classic one in the Chinese community. Do we have knowledge about ethnic differences in metabolizing and handling anticholinergic medications? Because that would reflect problems with generalizability.
That's a great question. Sorry, I've got an alarm going off here to keep me on track. Just give me one moment. I'm just going to mute. Sorry, folks. I am not aware of any work that looked at that. I'll be honest with you, but I agree. I agree. The metabolism would be interesting. I think sort of somewhat to your point, the fact that the entire study was contained within one country helps get around that issue, but that further work should actually look at whether there is a difference in metabolism, whether actually that changes the outcome.
Thank you. Go ahead, Michael. You're still on mute. We can't hear you, Michael, unfortunately. The options are perhaps to type it into the chat box, Michael, if you'd like, or reconnect the microphone.
No. How about now? Yeah.
Oh, now
okay.
Now you're live.
Yeah. My microphone wasn't on. Okay. It was a great study. My concern is you mentioned that, well, geriatricians are not likely to prescribe anticholinergics, of course, but the vast majority of prescriptions are not by geriatricians for older people, by family doctors. And the other issue is, according to ODB, most anticholinergic drugs of common use are not prescription drugs. And I think the real issue, and I see it sometimes just while I'm waiting in line at my pharmacy, people buying over-the-counter cold and cough medications. And during the season, it's rampant. If you go to Costco and you see people, what they have in their carts. So I think the real issue is not prescription anticholinergics. It's either having a method where anticholinergics for people who are older actually have to be discussed with the pharmacist, as we do with other drugs, or a massive education, because these drugs are prescribed all over the place on television. I mean, NyQuil and all of them. So that, to me, is where the real public health issue is in terms of decreasing the use of anticholinergics.
Yeah, and I would highlight too that the common anticholinergic medications that we get over the counter for things like indigestion, or things like dizziness, or things like reflux, are actually, they could be harbingers of an impending cardiovascular event as well. And so are people accelerating their road to an MI or something like that, as well as a whole other question that, of course, this study does not address.
Thank you. Go ahead, Gary.
Farid, great job. Enjoyed the presentation a lot, very thorough. And certainly agree, and you pointed out the limitation that the over-the-counter medications cannot be included, which is and as Michael has pointed out, it's a huge problem with a study like this. And maybe a bit along those lines, was any information provided about the classification of anticholinergic medications that were prescribed during the 30-day window that could give us some hints? Because as you suggested, maybe it's the symptoms of the impending cardiovascular event that's leading to prescription, and maybe having a sense of what the classification of drugs, maybe if there was a disproportionate.
They do. Antihistamines were by far the most prescribed, followed by gastrointestinal antispasmodics and diuretics. So certainly drugs associated with meant to treat symptoms of an impending cardiovascular event were certainly possible to be prescribed. The authors claim that doing that future analysis, or the analysis, the control crossover, addresses this, because they're dividing by the risk of patients who are actually almost 3 months away from an MI or a stroke or what have you. So they do show that that is actually an effect. The odds ratio for that analysis was actually high. So just a basic case crossover analysis cannot distinguish that effect, which is significant.
Thank you. In the chat, Karen De Silva agrees with you, Michael, on your point for over-the-counters. And Farid, perhaps I can ask, some of these anticholinergic drugs that you mentioned have been tested in randomized controlled trials, and I think probably in fairly high sample. And I wonder if the signal comes out in randomized data that new starts of these anticholinergic medications yield these outcomes, because I wonder if that's another source of information for this.
So it's not something, I have to admit, it's not something that I was able to look at. But yes, individual data in a prospective view would be useful to sort of comment on this, especially since we know the categories of drugs in this study and how prevalent they were. You know, like antihistamines, 68% or 69% were used. So I think there's enough indication here that this is that we should go after this information, but not something I did on this instance.
I think about the for overactive bladder that there should be adverse effect profiles from randomized older adults. The other question I have is whether or not, I don't know how it would be incorporated, but rather than the scores of anticholinergic burden, if any, I know there are assays to measure anticholinergic burden in the blood, but you know, whether or not there's any biomarker that would you know, be tied to it.
Right.
But not in their database, obviously, and timing would be difficult.
Yeah, I think like one of the strengths of the study, which is the ability to analyze so many patients, is actually presents you with a limitation, is you can't do that type of analysis. That data is not available. So.
Great, thank you very much. Any other questions or comments from the audience? Specifically, Colin, we have so many participants from the community. We'd love to hear from our community participants. If not, I echo Gary's applause and congratulate both Farid and Chandni this morning for excellent presentations, as always. And Barry also articulated that in the chat, how great our trainees truly are. As a reminder, the survey for the evaluation will be coming your way momentarily. And next month, as an announcement, there is no journal club. We hope to see everyone at the Canadian Geriatric Society annual scientific meeting. So we will see everyone again in this setting in May. Thank you all very much and enjoy your day and weekend.